Dr. Radha Ramanan to be the chairperson in the absence of Dr. Amit Shah and Dr. Sharad Babu. They're already on the dais. Sir, call the first speaker.
Good afternoon. I think we are starting a little late, so we have to stick to the time. Welcome all the people and the chairpersons. Okay, we won't take any time for introduction and all these things. I think already Dr. Rajanand has introduced the chair people. And Dr. Anurag Misra, you are ready?
Yes, I'm ready. I'm just waiting for the.
Okay.
I proceed to just to answer your query, sir. The idea came from what I normally do in my practice. It's just that more than the power, what I would be lamenting on is actually the finesse that you get from BSS. In fact, that was going to be my introductory statement before I could proceed with my presentation. We use viscoelastics in cataract surgery basically to achieve two purposes. One is the endothelial protection, and there's no substitute to that when it comes to protecting the endothelium mechanically by forming a layer over it, or under it to be more specific. And the other is space formations. For space formation in cataract surgery, we actually don't need the services of BSS, is what I came up with an idea. And then post-nucleus management in particular, where we actually don't need any endothelial protection, I use everything and I conduct all the steps under the cover of BSS, and I do not like to use BSS. And if you ask me why, then the answer is in the intracameral environment inside the eye, what circulates is the aqueous humor. And the BSS has got more chemical affinity to the aqueous humor than the visco has. So why should we use a foreign substance which is not really the eye's inherent constituent instead of something that we have available in our hands, which is much more mimicking the aqueous humor in its chemical composition. So let's go to certain videos. We all implant, most of us implant IOLs under BSS, but where we take a step back is actually the multi-piece IOL. The multi-piece IOL we normally tend to implant under the cover of viscoelastics. When multi-piece gets folded into the cartridge, it does so in two ways. One of the ways is the advancing haptic forms a sigmoid shape, a hyperbola kind of a shape. The other, when the haptic actually stands out, it stays straight because it's not a foldable thing in the multi-piece IOL. So I adopt different techniques to implant both of these IOLs under the cover of BSS. Let's look at the haptic being bent in a sigmoid fashion or in a parabolic shape. There, the cartridge is made very parallel to the eye. If you make it a little vertical or oblique, what tends to happen is the haptic gets kinked and there is a fold and acute angulation of the haptic which doesn't recover. So in the bag, it does not stay in the middle. The positioning inside the bag is not that good, and the overlap by the CCC is not that good. So if the cartridge is made very parallel to the eye, then it goes in smooth without bending it at any point. The second is this particular pattern of folding of the haptic where it stays stout and straight. Therein what you have to do is, and all the while the left hand has the 23 gauge cannula just flowing in BSS from here. Herein the haptic actually rotates 180 degrees. So you have to wait till the advancing haptic rotates. There it starts rotating and it occupies its position on the other side before you start rotating the rest of the IOL end. If you don't do that, then there's every possibility of the optic actually going very close to the endothelium and mechanically touching it, producing a destruction. So these are the two different ways of implanting a multi-piece. There's no reason why we should shy away from it. CTR implantation. This was one of those cases wherein I was just doing the IA after nucleus management was complete, and I suddenly dragged the bag along with it. Look at that. It's dragged the bag. So I tried to inject some viscoelastic to free the capsular bag which was caught in the aspiration port, but I did it wrongly at the beginning. I pushed the viscoelastic from the same side from which the dialysis had happened. It was not helping me. So I switched hands, took the IA cannula in my left and proceeded from the other side and injected some dispersive viscoelastic to flatten the bag out and form the equator again, and it got released from the aspiration port. Very carefully, the rest of the cortex was washed using a bimanual IA, which is not my preferred modality of IA routinely, but in this case I had to switch over. But rest before implanting the IOL, there's no reason we just need space formation here, and the bag has to be inflated, which the BSS is already doing. So we don't really need to be conservative in this and fill the bag again with viscoelastic. So with the same 23 gauge IA cannula which is there in the left hand, the CTR injector goes in and starts injecting the CTR. The only thing we have to keep in mind here is the injection should not happen from the place where the dialysis has happened. You can see the eyelet rotating inside the bag beautifully at the equator, and then you take the IA cannula in the left hand and just nudge the trailing eyelet for it to occupy its position in the bag, and then the IOL can follow in to occupy its position which is designated. PPC and vitrectomy. This is one of those cases where I saw that there's a lot of asteroid hyalosis in the vitreous space. So I decided to go in with the PPC with a micro-rhexis forceps in the right hand, just the BSS cannula in the left. You don't need to inflate this eye with viscoelastic at all. There's a toric IOL which needs placement as well. And then I take this with the same swift motion, the right hand just switches the instrument, and then I go and do a deep vitrectomy to clear out all the asteroid hyalosis from the vitreous cavity. Now, asteroid does not hugely cause a reduction in visual acuity, but it might just create that difference between a 6.6 and a 6.9. And there's no reason why I should leave my patient behind, because I'm implanting a toric and I'm promising him good vision, spectacle independent in the post-op period. Look at the red glow coming back to the eye when the asteroid hyalosis are cleared. These vitruses are very fluid, so you can comfortably go deep, do a vitrectomy and clear out all the asteroid hyalosis from the visual axis and leave the patient behind with a nice PPC sitting at the center with the toric IOL aligned. Explantation of pupil expanders. This is another area wherein BSS can help us. This is a Gupta's ring, an Indian-made counterpart of the Mulligan, where it is dislodged. Of course, to implant this particular ring, you need a 2.8 millimeter section instead of a 2.2. But look at the way the IA cannula is supporting the ring. I'm not allowing the ring to get dislodged from the pupil, come up and then straightly hit the endothelium, because there is fluid circulating in the anterior chamber, so we have to be a little careful. But one by one, all these scrolls can be disengaged from the pupillary border, while the left hand is supporting the pupil expander from up above so that it doesn't pop up. The fluid current does not cause it to elevate and then hit the endothelium. Then one of the scrolls is aligned with the main wound, and you can just take a McPherson forceps. So unlike the Mulligan, this doesn't have to go into an injector. So you can just pull it out. It's a 2.8 millimeter section any which way. So grab hold of one of the scrolls. Since most of these patients are toric IOLs again, and I hate implanting toric IOLs under BSS in particular, or even aligning them. So I exclusively use BSS for implanting torics, because the alignment always takes a hit if you use viscoelastic and give them a medium along which they rotate. However, if you're implanting a Mulligan, like in this case, again a toric implant, there also the explantation can happen under cover of BSS, but the principle remains the same. Right now, because Mulligan is a little difficult a ring, more than Gupta's at least, to disengage, because it is mechanical or dynamically a little different in shape. So right now the cannula is actually levitating it so that it lifts up, and then the hook goes in and captures one of the scrolls, the distal scroll, and then the cannula comes up to protect it, hitting the endothelium. The side scrolls have to be given a little bit of support with the second instrument, which I do now, again with the BSS cannula, no Sinskey hook is required. And then the distal scroll, while it dislodges from the optic, a counter traction has to be given, because it kinds of bites into the pupillary margin. So again, that can be done with the left-hand instrument, which is the IA cannula in this case. And lastly, there's a pediatric cataract wherein the IOL implantation is happening here as I have the BSS cannula in the left hand, and virtually everything, all the steps that follow this are done under BSS only. So starting with the IOL implantation, rotating and occupying its place, the vitrector comes in the second hand and then produces a PPC and a good anterior vitrectomy to remove the scaffold support for the lens epithelial cells to grow in the post-operative period. And then once it is done, while the BSS is filling up the anterior chamber, you can also take the bite under the cover of BSS. No need to put in an air bubble. You just can puncture the cornea and the sclera together while the BSS cannula is still in the right hand, and then you can just leave it. And we know that it's not exactly a tight suture, so you just make little a little taut so that the angle and the wound is supported tangentially. So that's about everything that's to be done on BSS, and I do under BSS. Thank you so much for the kind attention.
Thank you, Dr. Anurag. Actually, in your hand, all the procedure was going very smooth. But to a fresh person, I am little worried because the 3-piece IOL, how we unfold in the posterior capsule and CTR, the haptics, when you release it through BSS, it will be traveling so fast compared to Visco, no?
Well, it is not a bimanual injection. I think, I mean, that's probably the one subtle message that I would like to stoop and, submit with all honesty and a very soft baritone in my voice. I don't think it is actually that difficult. It's probably our mindset. We just don't want to accept that it is. I mean, we just want an extra sheet of coverage with the viscoelastic. Otherwise, BSS actually does a magnificent job in inflating the anterior chamber and gives us space to do everything. It doesn't travel fast if we do not push it fast. We just have to understand the mechanics. And I always trust the injector more than the manual method of implanting the CTR, because the injector is so well designed that you can actually dictate where it goes and where it rotates. For a dialysis which is more than what you saw in this case, maybe 4 to 6 clock hours, I might not do this. I might just be tempted to inject viscoelastic and then do, after supporting it with the capsular hooks. But for this many short, small dialysis, a BSS does a good enough job.
Yeah, Anurag, when you were showing us the 3-piece IOL going in, you can always rotate your thing
Pronate
and
your
see
hand.
that it goes like exactly inside instead of the tip showing up and down.
No,
That actually gave me a little bit goosebumps, like I was a bit terrified. Something might happen to the cornea and the PC.
if the advancing haptic goes into the bag, then you have no reason to have jitters, because then it will never hit the endothelium. If the advancing haptic goes into the bag, sometimes it unfolds in the anterior chamber, which you have to be careful about. So you need to have the rotation, the direction of the hand in such a manner that the haptic goes into the bag. Then you can dial in the rest of the IOL easily. But what you're saying is right. Pronating your hand is always an option. But with a proper loading and the optic remaining horizontal, most of the time it is not needed. It comes out in the horizontal plane.
Yeah, that's probably you're having one hand with the BSS and then it's a bit difficult. Maybe. It's a good surgery. Thank you.
Thank you.
Thank you, Dr. Anurag. And now I invite Dr. Parikshit Gogte for his topic, Recent Advances in Low Vision and Rehabilitation. Dr. Ashwani, topic of your interest.
Good afternoon, Dr. Radharaman sir, Dr. Sharad Babu sir, Dr. Pallavi Sinha ma'am, Dr. Rajan Anand sir. At the outset, I would like to thank the scientific committee for giving me this opportunity. This is not something that we ophthalmologists usually like to hear, and very few of us actually do. But then low vision and rehabilitation has to be an integral part of our practice. Because, yeah, now you can start the timer. And because when this is a quote by Swami Vivekananda, how developed a society is depends upon how it treats its weakest members. And the blind are some of our weakest members. And I have put a picture of Adolf Hitler, I should have put one of perhaps Churchill, is that till 1925, if you will look at the first 20 years, the Nobel Prize winners in the English-speaking world and the German-speaking world, they are almost the same. But then the German-speaking world fell under the pall of a leader who perhaps believed that those who are weak, who are useless, should not live. Then the great setback that it caused to them, it took almost 50 years for them to come out of it. We all know what low vision is and how that is classified. We know the causes of that. We know the prevalence of it. Every 5 seconds, one person goes blind. But then we have in our OPD patients of glaucoma, of retina, of end-stage disease who are blind. But there is still so much more. Their life still needs to be led. So the goals of rehab is, one, to maximize function, to enhance a patient's potential, to increase independence, and to improve quality of life, which is what we try to do in our low vision center. So one of the few things that we should learn is how to lead a patient who is blind, and this is something our OPD, OT staff should know, our receptionists should know. We all know about hand magnifiers, how they can be used for viewing near objects. There are stand magnifiers, reading from books, newspapers, and nowadays you get them in so many different shapes and sizes. And thanks to technology, you can order them on Amazon. So there are illuminated hand magnifiers, stand magnifiers, pocket magnifiers. And everybody nowadays wants to read, they want to look at their mobile phone. Similarly, for distance, we have telescopes, and telescopes are used to look at bus numbers, to cross streets, if a child sits in a classroom, to see the blackboard, traffic signals, road signs. And again, they comes in various shapes and sizes, binocular telescopes, clip-on telescopes, handheld telescopes, again, spectacle mounted ones, outreach ones. So there are so many that are available which were not there when I was doing my residency about 30 years ago. And it's not just optical devices. We have non-optical devices. They are used to enhance the visibility of the retinal image and optimize the use of optical devices. So simple things like a reading guide or a signature guide, because in many senior people, they want to sign a check, or they want to put in their name. Or if an old grandmother wants to do embroidery, there are needle threaders. Then there are notexes where you can actually put in a currency note and it helps you identify that, because for the last 15 years, as per RBI regulation, even the Indian currency has special notations that even a blind person can look at it. That is why notes come with different sizes, they come with different tints, so it becomes easier. In that respect, perhaps the dollar is considered the least disabled friendly currency, because all their notes from $1 to $100 are the same, which is not the case for others. Then there are absorptive lenses. A lot of people, they have oculocutaneous albinism, or they may be having retinal disorders, where if you give a specs that enhances contrast, reduces glare, eliminates UV light, it will help them. There are mobility assisted devices. There is a long cane training, and they can be used to search the ground ahead. It warns you of obstacles and drop-offs. In fact, nowadays in the smart city project that the government has bought, if you look at it, even the streets, the pavement is done in such a way that you can make out whether now there is an intersection going to come, whether this road is going to end and another road is going to stop. So all of this can be done using a white cane. So this is there, a part of life in the Western world, but it is coming to us also. So mobility devices, when I was at Moorfields, we would be so surprised to find that in our glaucoma clinic, people would come with a guide dog. So they would use the London Underground, they would change to tube stations and then come to Moorfields. And those dogs were allowed, and they were extremely well-behaved dogs. There are also nowadays portable strong torchlights. There are night scopes. But what has actually changed the game is assistive technologies in the last 10 years. So this overcomes the limitation of optical aid, like reduced field of view, working distance and contrast. And it can promote independent living and helps an individual. And nowadays we have a lot of senior citizens, even young disabled persons who have to live alone. So we have video magnifiers, computer magnifiers, softwares. We have talking scales, talking glucometers, other devices. I'll just take 2 minutes, sir. So they are image and text readers, they are color identifiers, screen descriptions, tags and labels, voice assistant. So this is a large Macintosh IBM compatible system where you place a piece of paper and it actually magnifies it about 20 times. And you can change color, you can split the full screen and have a look. There are vocalization or synthetic speech system, which if there is something, you put it on that, it will read it out to you. So you will have a small, you can say, earphone. It will talk back to you. So we have job access with speech, magic aid, non-visual desktop access. But this is something which I think will change the game. This is a smart vision device. It has AI in it. It's an artificial intelligence device, and we are a part of a team that is piloting it. And here it is actually a small camera that is fitted to the specs, and that takes pictures of it and tells the person what it is seeing. So it is like a virtual guide to the blind, helps them navigate. So it can detect the object. So if I was a visually handicapped person and putting this on, it will tell me that, okay, you are in a hall which is about this big. There are about 10 people sitting in front of you. There is a gentleman here with an orange sweater, another gentleman wearing a coat, another lady over here. It can tell their approximate age. It can tell the way they are sitting. So what we see in a glance within a second, in 10 seconds, it feeds in the same information. It can actually store 100 faces. So if there is a blind lady, she knows this is her milkman, this is her watchman, this is her son. So minute they are approaching, they tell that this person is now coming. So it increases safety. So it has a walking assistance, it has facial recognition, it is braille coded, it is a smart vision device. So it's linked to a mobile phone which has a rechargeable battery. And one wonderful thing is it can read in 9 Indian languages. So suppose I go to Tamil Nadu, I can't understand a word of Tamil. It can read a thing in Tamil and it can translate in English or Hindi and tell me what is written over there. So it has so many more, you can say, help. So this new rehab thing is something that all of us ophthalmologists, in our clinics we have patients who cannot now benefit from either surgery or from spectacles or from medical this. So I think it's a duty of all of us to refer them to the nearest low vision and rehabilitation center, because there is so much more that these people can do in their lives. They may not be able to see, but they are still able to live. And I think we ophthalmologists have a very important role to play in this. Thank you. Thank you for giving me this chance.
Thank you, sir. I think we have very little time left.
Okay. And Dr. Soumya? Right. So we have one speaker less maybe.
So, thank you to the chairpersons. I'm showing you how to manage a subluxated case. Basically, in this one case, almost all the things that you would do in a subluxated patient, cataract patient. Now, this is fashioning the reverse scleral flap, or the what's it called? Hoffman pocket, yes. Forgot. So fashion the Hoffman pocket in a, before you make your incisions so that your eyeball is rigid. Stain with trypan blue, 2.2 or 2.8 millimeter incision. So this, in this patient, the as you can see, the area of zonal adhesions was pretty large, and after initiating the rhexis, it was difficult to do the rhexis because the lens was moving around here and there. So in my left hand, I'm using a capsule grasper just to grasp the capsule so that the lens is stable, and then fashion the rhexis. The most important step in a subluxated cataract or a subluxated lens is being able to do a rhexis. If you're not able to do a rhexis, you have to resort to lensectomy, vitrectomy. So the first challenge has been overcome, and then using this railroad technique, proline suture, 10-0 proline suture, on which I have loaded a Ahmed segment. So 2 millimeter away from the limbus, in the area of the Hoffman pocket, the needle is exteriorized. Both the needles are exteriorized using a bent 26 gauge needle. So one has to be careful in this particular step so that you don't hit the lens. And then implant this CT segment. Generally it doesn't go through a 2.2 millimeter incision, and you have to enlarge to a 2.8. And then guide this segment into the bag. Then using the capsule hooks, you have to stabilize the capsular bag. So right now, I'm not going to fix the CT segment. It is just guided into the bag. You can see it is here in the bag. And then using these 4 capsule hooks for support. And this is a pretty hard cataract. So hydrodissection and then direct chop. This is pretty routine. The only thing is that you have to be careful in the lateral separation of the nucleus. You shouldn't separate it too much. Otherwise, you will cause greater stress on whatever zonules are left behind. And slow and steady wins the race. And here you have to be slow. You cannot be as fast as you would in your normal cataract surgeries. So remove the last bit slowly. Then the epinucleus removal and placing the single piece intraocular lens into the bag. Remove the cortex. And then, as I noted that there was slight decentration of the intraocular lens, I went ahead and placed the CTR through the side port. There you go. And of course, the MS segment was sutured in the scleral pocket. Thank you. If you have any questions, that is.
We should ask Pallavi if she has any questions. Do you have any questions, Pallavi?
Okay. I think he has stopped before time, so we have time for 1 or 2 questions.
Just wanted to invite Sharad. Wonderful management indeed. May I know what is the reason of subluxation in this?
Trauma.
Trauma. So yeah, so you can do all that juggling in a post-traumatic subluxation because expectedly one segment of the lens is dialyzed, but the other segments are stable.
Yes, healthy and stable.
It's a progressive dialysis, then possibly all these maneuvers are going to dialyze it more and sink it more. So there are 2 steps which I would like to do differently. Wonderful management, and the order was absolutely spectacular. But before staining or painting the anterior capsule, I would always plug the dialyzed portion with dispersive viscoelastic because very commonly these dyes go under the
Yes.
surface and then mar the red glow for the subsequent
Yes,
steps.
yes, very true. It has happened just day before yesterday.
Yes, it does happen at times. So it's a good idea to plug that portion so that the dye does not leak into the posterior surface. The other thing is before implanting any ring, particularly the CTR, I always remove or loosen out the capsular hooks. In fact, disengage them completely because if they are tented, there is a tangential pressure in that particular segment. And when you are rotating the CTR, the eyelid goes and hits that area or rotates through that area which is tangentially pressurized already with the help of capsular hooks because you're supporting the equator vertically.
Yes.
It just might rupture that area. So I always tend to disengage them, put in the CTR. If I'm doing it midway in the surgery, then I put the capsular hooks back. If I've completed the nucleus management, then I completely remove it and then proceed with the CTR placement and then.
Yeah, so as you saw, I had removed 3 of them, just left one
Yeah, I saw that.
before placing the CTR, because I agree with that point. You don't want to tent the capsule at the equator.
And the third and final concluding point is I'm not a very big proponent of the offense pocket anymore because in some cases it actually causes a very disturbing bleeding. And if in the process of making that
Initial, yes, it bleeds in the initial part.
if you have incised the conjunctival insertion somehow and it bleeds from that point, then it causes a ballooning of the conjunctiva. Of course, it can be managed by doing a peritomy and then cauterizing and doing a swivel flap on the other side. But yeah, I mean, maybe it takes a few seconds extra, but I still prefer to do a peritomy nowadays and not really rely on the
Hoffman pocket.
pocket punch.
Yeah,
Yeah.
so I mean there are various ways to skin the cat, and it depends on your preference and technique and what you believe works in your hands. So yeah.
That was a nice discussion by 2 experts. And now I invite Dr. Samiksha Agrawal, and her topic is tubercular uveitis.
Yeah, go ahead.
Yeah, at the outset, I would like to thank AIOS for this opportunity. So, before starting with the details, I'll start with an interesting case. This was a 35-year male which started seeing black spots in his in front of his right eye since 1.5 years. So patient has been having similar complaints in the past and he had shown to 3 to 4 different ophthalmologists, and every time he was given either IV or oral steroids. So on searching the old records, you see there was that exudate seen on the macula, there was some subsensory fluid, and he was given systemic steroids at that time. Later on, he went on to develop subretinal abscess in the nasal area, and again, when they did the investigations, the MANTU came negative, and the quantiferon gold TB again came negative, and on consulting with the pulmonologist, they again started with IV steroids. So when he presented to us, there was multiple choroiditis patches could be seen, and on OCT we saw there was some vitreous cells, there was some retinal fluid also, so the disease was still in the active stage. So again, we repeated few investigations, and again all the investigations came out to be negative. The CBC was normal and quantiferon gold TB was again negative. So on the basis of clinical picture and investigations, we diagnosed it as presumed ocular tuberculosis, and we started him on anti-tubercular treatment. So on his first follow-up, the vision also improved significantly, and we continued the ATT, and he had not been complaining of any recurrence of his symptoms since then. So as we all know, tuberculosis is a great mimicker, and it can present as for anterior and posterior segment involvement. In anterior segment, we can have lid granulomas, necrotizing scleritis, sclerokeratitis, and episcleritis. Again, you see there is diffuse scleritis in this 35-year-old female with history of fever and night sweats, and again the MANTU was positive. So in anterior uveitis, you will have multiple nodules. You can, especially the Koppe's nodules, mutton fat precipitates. Also, you can see tubercular granulomas in the AC angle. Again, in intermediate uveitis, you will have blurred vision with floaters, snowball opacities, and peripheral vascular sheathing. And posterior uveitis, you can have choroidal tubercles, choroidal tuberculoma, subretinal abscesses. Again, serpiginous like choroiditis, neuroretinitis, panophthalmitis, and endophthalmitis. This was a case of tubercular meningitis. Here we can see multiple choroidal tubercles in the fundus. So through the fundus picture also, you can make a systemic diagnosis. Again, choroidal tuberculomas generally present as a large solitary mass and may mimic a tumor. So this was a large, massive tuberculous choroidal granuloma. And here in this patient also you see there are multiple choroidal tubercles, and on starting with ATT and systemic steroids, you see that the patient has improved significantly and the vision has gone back to 6/6. Again, this was a 31-year female with solid choroidal choroiditis patch, and again on investigation the MON2 came positive. Again, many of the patients who can't afford quantiferon gold TB, on the presumed clinical diagnosis, we start them on ATT, and usually they respond. As we all know, tuberculosis is endemic in India, and almost 20 to 30% patients come out to be MON2 positive. Again, on the multiplication of the bacilli in the caseous material, they can lead to subretinal abscess, and they can have disseminated tuberculosis. And this was a 13-year-old girl with miliary tuberculosis, and optic nerve head TB abscess can be seen in this patient. So serpiginous choroiditis, it is believed to be autoimmune in nature, and relentless progression is seen despite the administration of systemic corticosteroids and immunosuppressive agents, and they usually respond to ATT. So we need to differentiate the tubercular serpiginous-like choroiditis from the classic serpiginous choroiditis, where we see that there is no concomitant vitritis, usually seen in the peripapillary region, and usually bilateral, whereas in tuberculous cases, you see there is some vitreous inflammation. It is usually starts in the posterior pole, and asymmetric involvement can be seen. Again, if the patient presents very late, like in this case, you see that already it has scarred, so no further treatment is needed as such. Again, if you see multiple paravenous scars, they are pathognomic of tuberculosis. Again, tubercular retinal vasculitis, Eales disease is commonly seen in young healthy male patients, and usually there is presence of periphlebitis. So this was a patient, 20-year male with periphlebitis, and multiple choroidal non-perfusion areas were seen, and on starting with ATT with steroids, you see beautiful resolution of the subretinal fluid, and there was significant improvement in vision also. Again, if there is recurrent vitreous hemorrhage, and in spite of giving ATT and on doing lasers also, if the patient is not responding, you might have to go in and do vitrectomy also. Again, in disc involvement, you will see papillitis, papilledema, neuroretinitis. And like in this case, this was a patient where you see that peripapillary hemorrhages and disc edema is seen, and on starting with ATT, the disc edema has completely resolved, and the patient has responded beautifully. Again, you have to do FFA in patients where you have to rule out any active lesion. Like in this case, there were some paravenous scars, and if you see on the FFA, you see there is some disc leak. Again, endophthalmitis and panophthalmitis if there is rapid progression of intense inflammation. And for investigations, you need to do chest X-ray, MON2, quantiferon gold TB. And on treatment, on chest X-ray needs to be done to see any hilar lymphadenopathy. And direct evidence, usually there is low yield, but in cases of endophthalmitis, you can see, you can do diagnostic vitrectomy also. So PCR, you can do aqueous and vitreous humor. PCR sensitivity is good. And as I have already discussed, the FFAOCT findings. And treatment, usually the all the 4 drugs are given for initial 2 months, and later on followed by 4 to 7 months of 2-drug regimen is followed, and concomitant use of corticosteroids is necessary to limit the damage to ocular tissue caused from delayed type hypersensitivity. Again, you have to look for side effects of ATT, like ethambutol toxicity is dose related. Again, central scotomas, disc edema, disc hyperemia, and optic atrophy, retinal edema needs to be seen. Thank you.
Thank you very much, Dr. Samiksha. Any questions? Yeah.
Yeah, come, Soumya. Soumya, you come and then get things ready.
any clinical finding of tuberculosis he had? Why was the ATT started? Okay.
I'm sorry.
I think
Yeah,
I think
we
you
will
can
take this discussion
yes.
later. I think you can
You
probably
can
have
you
a
can have a one-to-one talk there.
one-on-one because
We
they
just have
want us
5
to
minutes.
wind. Yeah.
We just have 5 minutes left, so I'd request Dr. Soumya to begin the presentation.
Thank you, sir. So today I'm talking on ocular manifestations of stress, and I thank our audience and our expert panel for being here across lunchtime. So it is really inspiring me to do a good job at this. So there is a lot of interest in stress in the general community, but I think us as physicians and as clinical personnel, we are not as tuned to it as we should probably be. And what is stress? So stress is basically our body's reaction to a challenge or demand. And in short bursts, it's very good because it helps us fight when we need to, like avoid danger or meet a deadline. But when it is chronic, it is a problem for us. And we've always thought that people are stressed because of their disease or because of their eye condition. But we also need to warm up to the fact that stress itself may be a causal factor of many eye diseases. So we have two basic responses to stress. One is the sympathetomedullary pathway, and the other one is the hypothalamic pituitary adrenal axis. Now the SAM pathway is basically an immediate response to stress, and it's a fight or flight response, whereas the HPA axis is a more slower response to stress, and it has a very high influence on the immune system as well. So like I mentioned, the SAM is an adaptive system for a flight or flight response. It has a very significant impact on something called Flamer syndrome, which we will come to in a while. And it's important for us because chronic stress can lead to chronic adrenaline release, and it can lead to consistently dilated pupils. And now as cataract and refractive surgeons, we know how important the pupil is to us in our patient outcome. So stress and its management is also very important. The HPA axis acts via glucocorticoids or cortisol, and this is a slower pathway. But the important point to note here is that chronic exposure to glucocorticoids can eventually be toxic to neural tissue and in turn retinal tissue. The ANS system, we know, is a delicate balance between the sympathetic and parasympathetic system. So if this balance is lost, then it takes a role on auto-regulation of our vasculature. And we know that a lot of diseases are precipitated by vascular dysregulation. An important thing to note is the prefrontal cortex shows atrophy in conditions of chronic stress, while the amygdala volume increases. Now, the amygdala volume enlargement is also found in patients with glaucoma, so we can conclude that there is probably a direct or indirect relationship between the two. In glaucoma, stress can precipitate raised intraocular pressure. It can cause vascular dysregulation. It can cause an imbalance of autonomic nervous system and immune aspects as well. I'm going to skip how it influences both normal tension glaucoma and high tension glaucoma. But basically, it works both in some way of vascular dysregulation. We know that stress can definitely increase inflammation by increasing the TNF-alpha and IL-6 factors, and they may also have a role in glaucoma along with having a role in inflammation. So Flamer syndrome was discussed or described by Dr. Joseph Flamer from Switzerland. So here he has described a personality type where patients have cold extremities, low blood pressure, increased pain sensitivity, probably a perfectionist or a type A personality. And they have found ocular associations with these patients with normal tension glaucoma, retinitis pigmentosa, retinal vein occlusion, preoperative ischemic optic neuropathy, along with some ear disorders and multiple sclerosis as well. Apart from malingering, there is something called non-organic visual loss as well, which is not perfectly explained by our ocular findings, and this may be precipitated by stress as well. Other ocular associations of stress would be AMD, retinitis pigmentosa, and myopia, both in precipitating it and in influencing how the patient handles once the disease has set in. We all know about dry eye syndrome, how, there are so many studies that have been done on how dry eye patients are stressed, but lesser so on how stress is precipitating dry eye. And we know that the autonomic nervous system can affect the secretion of tears, saliva, and other body fluids. So this can be an important factor in influencing the precipitation or increase in dry eye as well. And how are we going to manage this? Now, obviously, if it is stress that is precipitating some disorders, then the management is to reduce stress. Relaxation, psychotherapy is a very important factor, and a lot of studies have been done on intraocular pressure and stress, and it shows that certain ways of reducing stress can in turn reduce the IOP as well. I'm not going to go into the details of meditation, but that is something we must all explore. Things like music therapy, biofeedback therapy, autogenic training, these are all ways of handling stress. But what about us? Do we need management of stress? Are we managing our stress well? I think it's very important for us as doctors to be very careful of our health and our stress and our mental capacity, because we can't pour from an empty cup. So it's very important for us to be well balanced, to be able to take care of our patients. So we must also make sure we do some meditation and exercise. We must keep our close circle of friends active so that we are able to talk to someone when we need that help. So thank you. I think we wound up pretty much in good time. And if there are any questions, I would be glad to take it off the podium so we can free the stage for the next session. Thank you. Thank you. Thank you so much. Thank you. Thank you, Doctor.
Do we have the chairpersons of the next session? Yeah,
Yes.
Do
we'll
we
take
have-
the photograph.
The next section people are here?
Do we have a next session here? I don't see.